Very good afternoon to everyone present here. I'm Gaurav Ji, the second year Masters in Hospital Administration student at Prasanna School of Public Health, Manipal, India. It's my honor to welcome all the participants from 25 different countries to benefit from the seventh webinar organized by organized by the Manipal Health Literacy Unit known as MHLU in collaboration with the Asian Health Literacy Association known as AHLA MHLU aims to excel in health literacy resources, policies, and practices. The AHLA seeks to understand health levels across Asia from the research, educational, and policymakers' perspectives. Collectively, MHLU and AHLU are initiating a webinar series on health literacy for healthcare providers, researchers, policymakers, industry, academia, and the public. Before I invite the first speaker of today's webinar, I have some important requests to the participants. A small request to the distinguished participants to kindly mute your cell phones and the mic. You may post any queries, questions during the session through the chat box. We will be addressing a few selected questions considering the time limitations. In today's webinar, we will be hearing insights from experts on organizational health literacy and media literacy. Please note the speakers will be sharing their insights for 15 minutes. It's my pleasure to introduce our first esteemed speaker of today's webinar, Professor Dr. Stephan Vanden Broucke, who serves as a professor of health psychology at UC Leuven in Belgium. Professor Stephan is a renowned expert in a wide range of fields within health psychology, with a particular focus on health literacy and its crucial role in public health and education. He has been at the forefront of numerous national and international research projects contributing to the global understanding of health literacy and its implications for health outcomes. Professor Stephan also played a pivotal role in shaping educational programs, having participated in accreditations committees for training programs in the Netherlands and Switzerland. His influence reaches the highest level of policy making in public health as he has provided valuable advices to authoritative bodies in Belgium, the European Commission, and the Open Science Foundation. In addition to these remarkable achievements, Professor Stephan served as an elected board member of the International Union for Health Promotion and Education, demonstrating his commitment to advancing health literacy on a global scale. His work is not limited to academia. He is a member of the Technical Advisory Group on Behavioral and Cultural Insights of WHO and the Working Group on Social Research Methods and Advice of the European Food Safety Authority, the Scientific Advisory Group of the Asian Health Literacy Association. Furthermore, he holds the position of President of the Healthness Consortium, an initiative dedicated to enhancing health literacy in Belgium. Professor Stephan's expertise in health literacy and his dedication to improving public health through education make him a distinguished and influential figure in the field. We are honored to have him with us today. Over to you, sir.
Thank you very much, Dr. Gara, for these very kind words of introduction. And so I would say good morning to everybody, but I suppose that for you it's not morning anymore. For me it is, but I'm very happy to address this group of people who are interested in health literacy. And if I'm right, you should now see my slides appearing, and then I can kick it off with this presentation. So what I'd like to talk about today is health literate organizations, and I'd like to first of all position it a bit in the development of health literacy research, health literacy practice, and then move on to what we understand by health literate organizations and what the state of the art is, the state of play in the field of research and practice. But I think it's nice to see that that health literacy and health literacy organizations don't come out of the blue. We've seen over the past years an incredible expansion of research on health literacy and a growing attention as well. And we've seen that in the beginning, and I was very proud to be part of that, we saw a focus on measuring and documenting the size of health literacy as a problem of public health. But we see that now we move to the world of interventions. We try to change things with regard to health literacy, to address health literacy. Another movement we've seen is that it's not one literacy, it's literacies that become more important. So it's not just reading, writing, numerical skills, but also use of digital media and digital health literacy. Media health literacies has also come up. And we move also from intervening on a smaller scale to building the capacity of organizations, of policies, of governments also to address the health literacy problem. So it's a very changing and expanding and exciting subject. And one of them is that we see a focus that goes from more individual health literacy, to getting a bit more focus on the organization, where we don't only look at what individuals can do, but also what can organizations do for those who have not much health literacy. So we see that as a development, and I think it's a very nice development. I think it's an important one, and I tell you why. If you look at, so we see that this is where health literacy comes about. So we see that people who have little health literacy find it difficult to organize their health. And so we can, of course, measure the individual health literacy and try to improve it, or to make sure that people can function. We can also measure more the fit of health literacy competences to the demands, and then we can compensate, or very often it's health professionals who then try to adapt the way of explaining things or showing things using, for example, also more visual supports. But we could also make it in a way that, in fact, people need less health literacy in order to function. So if we improve the organizational structure so that people with little health literacy, with low health literacy, can also function, that's what we're talking about. And that's actually the concept of health literacy organizations. So why I was saying is we can position health literacy, organizational health literacy, as trying to not put the focus on measuring individual competences and then trying to improve them, or to answer to them when we meet with people who are low in health literacy, but to try to change the demands of an organization. And this makes sense, but because if you look at the real challenge for health literacy, we see that the capacity of people to answer to the demands is basically what health literacy is about. It's not just the people, it's also the way they are able or capable to answer to demands. And generally, healthcare systems are not very reactive to those demands. People with low health literacy often do not get the response that helps them, and that brings them often in sort of a vicious cycle where poor health literacy meets with difficult demands, and people get less convinced that they can do things, and this basically leads into a poor cycle. And so if we add more focus on the context, we can better answer and understand that problem. So this brings us to the concept of a health literate organization, and the concept is around for about 10 years now, slightly more than 10 years. It was Cindy Broucke and colleagues who introduced it by referring to an organization-wide effort to make it easier for people to navigate, understand, and use information and services to look after their health. So you see the meaning of health literacy is very present here, and it refers to the concepts and the process of health literacy, but applied to an organization like a hospital or a counseling center or a healthcare organization, or even a health funding organization, for example. So this was the beginning of this movement, but we've seen that over the last 10 years, there's been a development, not only in terms of research and application. We've seen that the conceptualization, the characteristics of a health literate friendly healthcare organization has been refined. We see more and more within organizations, we also see more offer. We see that, for example, the ways in which patients are discharged from hospitals are facilitated, are made easier. And we see that the barriers, that there are also more recognition of the barriers to develop and implement organizational health literacy. We also see tools for health literacy that are being piloted and introduced, and we see guidelines to assist organizations to develop their organization into a health literate organization. So if you're okay with that, I'd like to develop those points a little bit more in the rest of this presentation. Coming to the conceptual frameworks, if we want to really change organization to make them more health literate, we have to understand what we're talking about. And so a number of theories put the focus on the what of organizational health literacy. Don't try to read what's on the little graph on the side. It's just an example and an illustration of how complex an organization can be and how complex addressing health literacy within an organization can be. So these what theories, and the one I just showed, the definition of Broucke, is one of those. They look at organizational health literacy as multidimensional, and so they try to see what are the dimensions. They see low health literacy as a vulnerability of people, and they try to see how can an organization address that, and they propose interventions to that. The how theories are more looking at the theory behind an organization, and they look at the capacity of organizations to develop and offer healthcare that's accessible for all. And so they draw more on existing theories in other fields, such as healthcare management, organizational science, implementation science, quality improvement. So those two come together in the topic of health literacy, that's organization. So a few organizational theory examples. I already mentioned the Broucke theory, or the Broucke model and definition. They were admittedly the first who brought it into the domain. And so they developed 10 attributes of health literate organizations. So simply a list of 10 characteristics that a health literate organization should adhere to. And they say that by paying attention to those 10 attributes, you can develop an organization that's more health literate friendly. So it's simple in a way because it's just a list of attributes, but of course it's a bit inductive. It's not really based on theory. It's not really a theoretically based approach. The how theories try to accommodate to that, and one of the more known ones is in Europe, the Vienna concept of health literate hospitals and healthcare organizations. It comes from the health literate hospitals network that's WHO driven. And so it looks at an organization like a hospital from a settings perspective. The settings perspective in health promotion looks at organizations and how organizations can be changed to be more health promoting. And so adapting that to the idea of health literacy, you come to this Vienna concept and looking at the health literacy of patients, but also the healthcare providers within the hospital and the organizational system of the hospital, and even the population and the network around it. Another theory would be the organizational health literacy responsiveness framework, which looks at health literacy, organizational health literacy, as a response of healthcare organizations to needs of the community. So you see there's a lot of thinking about these frameworks. If you now ask me which one should be followed, I cannot answer that question. I think we still have to look at the results of testing their feasibility as we go along, and this is actually the state of play that is developing now. Now, in order to apply and test, we need guidelines and toolboxes. There's quite a few that are becoming available. So I'm not going to list them all, but you can see that some are very outreaching, very large, and others are very specific. They also depend on the context in which they're implemented. They usually combine assessing using the measures that we have with trying to address barriers to seeking and finding care for people who look for care. They use a variety of tools and methods, and then mostly involve recommendations that come out of the measurement. Mostly they are applied for general healthcare organizations, so they apply to any kind of organization that works in the health field, but some can also be very specific, for example, pharmacies, hospitals, or primary care. So some of the measures that I was referring to, one of the older ones is the Health Literate Healthcare Organization Scale, so that looks at the 10 attributes. Some have refined that a bit more and looked at indicators of those 10 attributes. For example, an Australian tool, the N11 Organizational Health Literacy Self-Assessment Resource. Some have, I'm not really going to name them all here. You can read that on the screen. But so some are very detailed and other are a bit more general. So, but there is a choice already of tools that allow to measure the dimensions of organizational health literacy within an organization like a hospital. So, for example, the Vienna Health Literate Organization questionnaire uses 9 standards, and then you can see that there's a series of substandards. And what you can do is to check with the staff and the people who are responsible for the hospital to what extent each of these standards are being met by looking at the substandards that help to operationalize them. To implement health literacy, we can use those tools, we can use those guidelines. So what comes out of that? Well, actually, the detailed implementation of health literate organizations so far has not really been documented very well. So we have a few reviews that have been published in the meantime. Farmanova, for example, did a study on the guidelines that facilitate the implementation of health literate organizations and on the use of evaluation tools. And the finding was that, well, there's progress, but we have not much proof as yet. We have done some research in Belgium as well. We have looked at the using the N11 tool at the making of and installing of a health literate organization in hospitals in Belgium by interviewing doctors and nurses. And we have very recently, we had Gilles Henrard, who has also looked at 3 hospitals that used the Vienna Health Literacy Organization tool in Belgian hospitals. And what we find, and what is also reported in the literature, is that it's extremely valuable, but also not easy to implement. Firstly, because health literacy is not always a priority. It's not always the thing that comes first and that gets most commitment. Decision makers often don't know really what it is. You see that health literacy is still often seen as a problem and not as an advantage to the functioning of the hospital. And then there's all the practical details, like not the support from the organization, not enough time, not enough resources, but also the complexity. So my feeling of it is that we really need to facilitate the installation and implementation of organizational health literacy within organizations, because otherwise I think it'll be a very difficult to sell point. So to conclude with this introduction, and my apologies already for taking a bit more time due to the technical problems, but I think we are embarking on a very interesting, novel topic within the health literacy field by looking at organizations. And I think it's also necessary because it can help healthcare organizations to be better equipped to address health literacy. So by looking at organizational health literacy rather than individual or in addition to individual, we recognize the fact that access in healthcare services is not the only factor that makes people use healthcare, but also the factor that we understand by health literacy. And so by using guidelines, we can orient and help organizations to introduce a health literacy policy within their organization, based on good practice, based on experience, but we have to still make them available and make them tested so that we can see how well they function and we can fine-tune them. There are challenges to implementing health literacy organizations or organizational health literacy. They're similar to the ones that you can find in other changes within the healthcare sector and more specifically in the healthcare organizations. But I think by looking at the concept and the concepts and the development that are ongoing, I think we are looking at the future of organizational health literacy and of health literacy as such. So I would like to stop my presentation here. I'm going to try to log out and go back to the presentations for you. And I give the word back to Dr. Prof.
Thank you so much for your enlightenment talk, sir. So let me introduce our second speaker of today's webinar, Dr. Nurjanah, MPH. Dr. Nurjanah is the Vice Dean of the Faculty of Health Science, University of Nurjanah since 2023. She has been a dedicated lecturer in the Public Health Department at the same institution. Dr. Nurjanah is the Vice Dean of the Faculty of Health Science at University of since 2023. She has a dedicated lecturer in the Public Health Department at the same institution since 2000. Dr. Nurjanah has a strong educational background with a bachelor's in public health from University Dipanagoro, a master's of public health, and a doctoral program in medicine and health. She has taken leadership roles as the director of the Asian Health Literacy Association and currently as the head of the research department at AHLA. Dr. Nurjanah is a member of prestigious organizations including the International Union of Health Promotion and Education, Asian Health Literacy Association, and International Health Literacy Association. She is known for his dedication to public health initiatives such as founding the Tobacco Free Community and serving as the vice coordinator of the Semarang Smoke Free Area Network. Her research, funded by institutions like Johns Hopkins School of Public Health, focuses on critical issues including tobacco control, media literacy for preventing young smokers, health literacy, and the effects of smoking behavior. Dr. Nurjanah has made significant contributions to public health through research, activism, and leadership, establishing herself as a champion in the field of health literacy. Now, I would like to request Dr. Nurjanah to share her insights on today's topic. Over to you, ma'am.
Thank you, Kira, for nice introduction. Is my voice clear?
Yes, ma'am.
Yes. Okay. I would like to try to share my presentation. Is it show on your screen?
Yes, ma'am. Yes, ma'am.
Okay. Okay. Thank you very much. Good morning and good afternoon. Maybe in other part here is afternoon in Indonesia. Thank you very much. It's such an honor for me to be a speaker in this webinar, and also congratulations for Dr. Usarani and Manipal team for conducting the webinar regularly. And also distinguished previous speaker, Professor Dr. Stephan van den Broucke. Good morning. And all participants, yes, I am Nurjanah. I would like to share about the media literacy, some research and a case of media literacy program to prevent pre-adolescent of being smokers. We know that in this area, people exposed to the abundance of messages from various media, and now people can easily access the media, even making and sharing messages in the media without filters. So I think the media literacy skill is very important competency. So my presentation would be divided into 3 parts. The first one is health literacy and media literacy, and then the second one is the unhealthy media influences. I will take the top studies in Indonesia, and then media literacy to prevent young smoker program. Okay, we will look at the health literacy definition, like is well known, the competency to access, understand, appraise, and apply health information in order to make judgment and take decision in everyday life concerning healthcare, disease prevention, and health promotion to maintain or improve quality of life during the life course. And this is also the term, another term of health literacy that connected to media. In the term of health literacy and media literacy, we also know e-health literacy, EHL, and media health literacy, or MHL, in the context that are personal situation. There are personal situation and then situational condition and environment that influence the e-health literacy and media literacy. This diagram connected by Professor Levin Zamir. And then we move to the slide about the theoretical of the media literacy that may be very close to the health literacy. Media literacy is the ability to access, analyze, evaluate, and make a message in various contexts. So the process of media literacy is more likely to health literacy. It is to access, analyze, and in this process of media literacy, there are knowledge and awareness, and then analyze and evaluation, and also a creation of the media, and then do action for taking an action in everyday life. So there is another term of literacy. This is digital literacy. Maybe we can compare media literacy to digital literacy. Media literacy is a holistic study of media and it in its various form. While the digital literacy, a subset of media literacy that focus on the digital tools like social media or website. So digital health literacy is the part of media literacy, and both can help reduce the effect of the echo chambers and media bias. We know that in the media, in any media, in the message and media, it's not only in the good messages, but also there are many unhealthy messages in the media. So we move to the 5K question of media literacy. The number one is who create the message or the production of the message. Number two is what creative technique are used to attract my attention, because usually in the media is made by high technology or by the particular technique to attract the attention of the audience. And number three is how my different people understand this message different than me. Yeah, because different people can decode or understand the message differently. And number four, what values, lifestyle, and point of view are represented in or omitted from this message. And number five, why is this message is being sent? And then this is the 5 core concept of media literacy. And like in the previous slide, the number one is all media messages are constructed And number 2, media message are constructed using creative language with its own rules. And number 3, different people experience the same media message differently. Number 4, media have embedded value and point of view. And number 5, most media messages are organized to gain profit and or power. Okay, so we will move to the detail of the theoretical model of the media literacy from the paper of Broucke et al. 2006. And there are 3 domains of media literacy. Number 1 is author and audience. Number 2, message and meaning, and really and representation. And these 3 media literacy domain divided into 9 media literacy core concept. It's namely AA1, AA2, and etc. until RR2. Okay. And the problem is children and healthy message, maybe children exposed to unhealthy message in the media. Do they have a media literacy skill? So I will move to the case from Indonesia, because unfortunately Indonesia haven't signed the FCTC, so the regulation of tobacco control in Indonesia is very weak. So in Indonesia, children, people, everybody can see the picture like this, like in the left picture, when children go to school, and then there are a big banner in the street that it is the tobacco advertisement. And also they have many program, and the tobacco industry has many program for sport, for scholarship, for entertain, yeah, that sometimes it also include the children to be in the participant on the audience of the event. So it's the problem on Indonesia, and it's our concern that before our government can take down all the tobacco advertising, promotion, and sponsorship, the children should have media literacy to prevent them to be a young smoker. This is our national data that the children smoker prevalence in Indonesia increased significantly from 7.2 in 2013 to 9.1 in 2018. And then the age of smoking initiation among ever cigarette smoker also younger. And most of them start smoking before 13 years old. And then this is our study from Semarang, from city of Semarang. Semarang is a capital city of Central Java. We do the mapping of tobacco advertising, especially outdoor tobacco advertising in Semarang, and we put the red dot in the map. This is the map of Semarang city, and then there are more than 3,400 advertising, outdoor advertising there, and we also overline the tobacco advertising with school key points. So the gray circle is the school key point, and maybe it's embarrassing, but yes, more than 70% of the tobacco advertising within 300 meters from school. It means that children or circumstance around school is there are many tobacco advertising there. And then this is another analysis of the school. We have more than almost 1,000 school in Semarang city, and almost for 40% of the school inside the advertising hotspot. It means that in the hotspot there are more tobacco advertising than in another area. So it's very very embarrassing for us, but it's the reality that the children and the student may exposed to tobacco advertising around schools. And the analysis of this density of advertising tobacco advertising within 100 and until 300 meters from school in Semarang is also significant, that the closer the school, the denser the cigarette advertisement. We also have another study. This is the second study after the mapping, and we also on the do survey on secondary and high school in Semarang, and the result showed that the student at the school with a medium and high density of outdoor tobacco advertising were up to 2 times more likely to smoke compared to those with low density of tobacco advertising. And this is the percentage of the tobacco advertising promotion and sponsorship exposure to the children. And the most media that expose to the children with the tobacco advertising is billboard, billboard and banner is the outdoor media, and followed by display on the point of sales, and then also on the television. We have the regulation on television that it ban the tobacco advertising. It ban only from the 5 a.m. to 9:30 p.m. So after that, in the night and then in the early morning, the tobacco advertisement also show in the television. So this is the intention and smoking behavior. We do the paper-based survey and online survey. The paper-based survey, more the student with in the paper-based survey have the intention to smoke than in the online survey. So media literacy is important for children, particularly for adolescents, because the children should have a shield to protect them from inducement to smoke, and the media literacy to buffer the impact of mass media message on smoking and susceptibility to future smoking among adolescents. And then the smoking media literacy, we adopted the smoking media literacy by Primark and Sensa scales, has also good validity and reliability on adolescent, but it has not been used in the pre-adolescent population. So we tried to use the scales in pre-adolescent population, and the intervention should start from pre-adolescent because cigarette smoking initiation is getting younger. So how to develop a media literacy program for smoking prevention in adolescent? In Semarang, we make media literacy to prevent young smoker. This is the curriculum of media literacy for preventing young smoker. We have themes in need assessment, and we mapped in with the media literacy domain and the competency. And during the FGD with the children, they said that like to see in the animation movie and pictorial books. So we make a short animation movies and book for the student in elementary school. Okay. Yes.
Sorry to disturb. Sorry to interrupt.
Okay.
You can conclude your in 2
Okay.
minutes.
Yes. This is the process of making animation movie and book, and then the movies simple. And if you want, you can click the link in the presentation, and this is the instrument to do the media literacy survey. And then after we do the intervention in the intervention and control group, and the intervention effectively increase the media literacy score. And then in the path analysis of factor influence to intention to smoke, the media literacy negatively affected smoking output expectation. Then smoking output expectation also negatively affected self-efficacy. And then the self-efficacy had a negative effect on intention, and media literacy negatively affect attitude, but there are no significant effect of attitude on intention. And last is the total effect of the media literacy on smoking intention was significant. So the conclusion is the media literacy is a promising competency for children to face unhealthy message through media, such as preventing intention to smoke. This is my reference, and thank you.
Thank you, ma'am, for sharing your valuable insights on the topic. Now, I would like to invite Malianta Asmarani Kusumwardani, who is working as Secretary of AHLA Indonesia Country Office. Currently, she is working at Secretariat of Faculty of Medicine, University of Dian Nuswantoro, Semarang, Indonesia. Will be moderator for the today's panel discussion. Over to you, ma'am.
Okay, thank you so much, Dr. Gaurav. Can you hear my voice clear?
Yes.
Yes.
Okay, thank you so much, and thank you for the important speakers today, Professor Stephan and Dr. Nurjanah. And hello, everyone. My name is Melly from AHLA Indonesia Country Office. It's such an honor to be here, so thank you for Manipal Health Literacy Unit and AHLA, then giving me a chance to be moderator on this panel discussion. Now we will talk about subjects of our discussion today is organizational health literacy and media literacy, and we are open for questions and comments for all the audience. Currently, we have 68 participants on this webinar, but I apologize if I can't respond all the requests, but you still can drop your questions, comments, and maybe your experience on the chat box, or just simply you can press raise hand button, so it will be easier for both of the speakers. But now I'd like to ask the first questions to Professor Stephan. Okay.
Go ahead.
Okay, we know that when we develop an organizational health literacy, there are some theories about that, like 10 attributes based on IOM and 6 key areas for improving health literate organization from Health Literacy Iowa, even though, as you said, it's not always based on theories, but improvement from the ADRSnet frameworks. For those who successfully sustain maintaining the OHL, usually from these organizations, which step that usually experience the most difficult or challenging, and can you give us your wise thought about that and how we, the organization that want to start it or still trying implementing OHL to overcome it? Thank you, Professor.
Thank you so much for this question and for opening the debate. And I think it's a very good question. I don't know if I have the answer. I would almost say I don't have the answer yet, because I think it's a very rapidly evolving field, as I mentioned. And so I think it's important to note that we see a little bit like health literacy in general, that there's various developments taking place at the same time. And so that makes that conceptual approaches are being implemented in parallel rather than in combination. So as far as I know, there's no studies yet that have really compared one or the other approach or model. So the models that that I see are prevailing may be basically because they're better known, and not necessarily because they're empirically better. That being said, of course, I have personally a preference for models that are building on what we already know and that are not dropping the subject of organizational change just in the organization. And as much as I think the 10 attributes model is very easy to understand and easy to see the logic of it, I think it makes a lot of sense to look more at organizational change. And so now I put on my hat of a person who is linked to health promotion in general, not only to health literacy. I think we know quite a lot about the settings approach, and we have a very rich literature on how to change organizations like schools or workplaces or even cities into operational organizations that address the health of the people. So I think that being considered, I think it makes a lot of sense to draw on that knowledge to try and implement also the organizational health literacy topic. And so in that respect, I feel quite connected to the Vienna model, because that really builds on that. It builds at the same time on the concepts of health literacy we know and on health promoting settings that we know. And maybe, and that's why I said not yet, maybe we just have to wait a little bit until the results of studies become available and being published. So there's only 2 reviews that have looked at it so far. There should be more coming. And then maybe also look at different effects of different approaches. I'm sure this is a very unsatisfactory answer, but it reflects the state of play in the field. And so that's the difficulty of addressing a point that's in full development.
Okay, thank you so much for the answering. And we have 2 questions more about the OHL, maybe from Sporty or Dr. Carmen. Do you want to elaborate your questions, or maybe I will ask to the Dr. Stephan?
I
can
can read them in the chat.
Okay.
So there are guidelines and standards that are becoming available. So actually, some of the models that have been developed come with standards, and they also need a bit more specification. But so, for example, the Vienna approach is not only setting which are the standards and substandards, but also develops how they can be put in practice. And there's more of them. I did not give an overview in my presentation because it's a bit let many flowers bloom kind of approach. So people develop it and there's not real testing yet. So I think there also we'll have to wait a little bit, but it's certainly something that's being developed. And then with regard to self-assessment tools, are there any tools that have been developed after 2020? Probably, but I think I don't know if we should invest more in the development of tools and if there's a need for newer tools to develop. I think the tools that we have, and I'm more specifically thinking of MLiven, which is a very good operationalization of the 10 characteristics, and the Vienna tool, they are very, very well developed and logical. So, and we have, from what we've seen in testing them, is they work. But there's a caveat. I think you need to create the right take on it within an organization. So what you cannot do is to just go to an organization and say, here are the 10 characteristics. To what extent are they available? What we notice is that if you operationalize it, you have to be very careful to be integrating and including various levels of organizational. There's a tendency to focus on the management and sub-management of an organization like a hospital or a health insurance company, and that the people on the ground, like the nurses or the other staff, have no clue and have no idea what you're talking about. So from the research that we are now actually doing, this is a very obvious finding that if you want to be inclusive and you also want to look at the real organizational health literacy, not just that of the management, then you need to make efforts to include also people who are not in the management, but they are very often very distant from knowing what is health literacy and what can you do to make it so, or even recognizing the need for it. So, and that's where I think we need to be investing a bit more. It's to be at the same time inclusive and at the other time to value also the conceptual basis. So it's a challenge. We'll have an important meeting here in Europe in a few weeks, the end of November, where we're actually going to look at that with a number of experts, and maybe something will come out of that in terms of implementation. So thank you for that question as well.
Okay, thank you so much for the answering for the questions. So I have second question for Dr. Nurjanah. We know we can control the media, and from your presentations, we learned how media literacy is really important for the children. We know that the part of health literacy is to ensure easy access to health information, and our children nowadays are really close with social media. I want to know from your wise opinion how this media literacy can be distributed effectively through the children, as we know the social media have uncertain algorithm. Thank you, Doctor.
Yeah, thank you, Rani, for the question. Yes, maybe it's our problem now that we cannot filters the media that expose our children, because yes, the algorithm of the social media is run well, and when the also it's the problem when they also use the mother or parents gadget, and the algorithm also run that. And yes, I think the media literacy is one part of the skill that can be share or can be educated to the children since they are young. How they can how they have the critical thinking of the media. Yeah, it's challenging because in children maybe they have like can think the abstract thing. They maybe Dr. Stephan is the expert of this what is it, the development of the children, because the background of psychology, the children not really know the reality, like the adult people, like when they show the like in the advertising, they show the strong and the beautiful woman who smoke, and then they think that. And now, when I asked them about the media or the picture, they said that yes, I don't smoke now, but maybe when I getting adult, I will be like him, or I will be like her. That is the like they have to think that there is something message that behind the media. The media is maybe they are beautiful, they are strong, but actually there are some message that omit from the media. We should make the people care, and the children and the parents care, and also the teacher care about it. So I think educate the media literacy can start from the beginning, from the children. They can try to we can try to see in the media, and then the media, who is behind the media, who produced the media, and what the intention to show the media, to show the message on the media. So I think it's important to make children and people have a critical thinking about the message on the media from the beginning. Maybe Professor Stephan from the view of the psychology can add more about that.
I don't think I have to add very much. I think you've said it. And it's true that children, of course, in their cognitive development are more vulnerable to messages that are not going to help their health, but also especially at the age of adolescence or puberty, when they begin to get interested in smoking. I think one of the things that is very often against us is they have this tendency to feel invulnerable. Effects will be, or potential risks will be, cognitively reduced, and that is actually a development mechanism that's helpful, because it's the age where they have to explore and establish their identity. But of course, from a health perspective, it's a disadvantage, because they will consider themselves less vulnerable than other people, which means that indeed they have to be really aware not only of the health effects, but also of the role media play. And that's exactly what you're talking about with the concept of media health literacy, that understanding what makes media work and what are the vested interests, and understanding where the message comes from is absolutely key. So I'm very, I think this is a very important topic, as you very nicely explained also in your presentation.
Yes, thank you.
Okay, thank you so much. And from our discussions, okay, Dr. Gaurav, even my time is over.
Yes.
Yes, ma'am. Thank you.
Okay.
Thank
Okay,
you,
we
ma'am.
finally come to the end of the panel discussion today. I hope you find it informative and valuable. Thank you so much for joining the panel discussions. And from this time, I give it back to Dr. Gaurav. The time is yours.
Thank you, ma'am. I would like to extend my heartfelt gratitude to our esteemed speakers, moderators, faculty, staff, and students of MAHE, members of MHLU Executive Board, and members of AHLU. In the end, I extend our heartfelt thanks to Professor Dr. Helmut Brand, Founding Director of Prasanna School of Public Health, MAHE Manipal, administration of MAHE Press and Media, and also all the supports we have received. I will not mention the names, but many thanks to each and every one of you who has contributed directly and indirectly to in conducting this webinar. Thank you all.